Hello everyone. Next, we'll take a few minutes to tell you something about the diagnosis of immune thrombocytopenia. And as we know, the pathogenesis is highly explored in the recent years, and we know it was caused by a loss of immune tolerance and mediated by immune-mediated platelet overdestruction and also megakaryocyte deficiency, or the decreased platelet production. However, the diagnosis of ITP is still a diagnosis of exclusion. In other words, we don't have specific methods to diagnose ITP. And the highest correcting rate of platelet diagnosis is close to 85%. In other words, still 15% of patients can be misdiagnosed. And according to the guidelines of International Working Group of ITP and the guidelines of American Society of Hematology, and also our Chinese guidelines on ITP, the diagnosis of ITP depends on the following criteria. The first one is a decrease of platelet number, which can be decided by automatic machines, cellular counter, and also can be decided by a microscope manually. We decide a thrombocytopenia according to 2 times counting in between 7 days. And the second criteria is that by microscopic studies, we cannot find other more abnormalities. The third criteria of diagnosis of ITP is that the spleen is not enlarged. In other words, there are no splenomegaly. If there is an increased size of spleen, and you have to consider other diagnosis first. And the fourth criteria is that in bone marrow study, a bone marrow cellular smear or biopsy, you can find increased number of megakaryocyte, no other abnormalities. And the increased megakaryocyte account for approximately 60 to 70% of patients. In other words, still 1/3 of patients, they have normal or decreased megakaryocyte number. And finally, you have to exclude secondary causes of ITP, which includes first, and pseudo thrombocytopenia caused by EDTA and very common used anticoagulant. And the incidence of pseudo immune thrombocytopenia caused by EDTA is closely to 0.1 to 0.3%. In 2015, we found in total 25 cases of pseudo-immune thrombocytopenia in Qilu Hospital, Qingdao Division. So there are not very few of this. You can find pseudo sometimes. You have to exclude them. Otherwise, if you treat them, that is an over-treatment or a misdiagnosis. And the second thing you have to exclude is an inherited or congenital thrombocytopenia. There are many kinds of inherited and congenital thrombocytopenia, but you can find this kind of thrombocytopenia according to 3 points. One is family history. You can find a similar patient in the same family. You can find 2, 3, 4, 5, or more. And the second point is that these patients, besides the thrombocytopenia, they have other abnormalities. For example, they have death. They have deficiency in the renal function. And they have maldevelopment of the joint or bone. So that's the second point you can find inherited and congenital. And the third point is that most of these patients, they have thrombocytopenia after birth. That is, After birth, they have already thrombocytopenia, so they have a long history of thrombocytopenia. And the third category you have to exclude is other reasons. Other reasons including drugs. And drugs, there are many drugs existed, and many of them can cause immune-mediated drug-induced thrombocytopenia. However, the most common three drugs you have to remember. The first one is quinine, and the second one is heparin, and the third one is Zantac. So these three drugs are very common used in clinic. So you have to remember, when you use those drugs, you have to pay attention to the platelet count. And the second category of other reasons is virus. There are, of course, many thousands of viruses existed. However, there are 3 or 4 very common viruses which cause immune-mediated thrombocytopenia. The first one is HIV virus, and the second one is megavirus, and the third one is HCV, that is hepatitis C virus. These 3 viruses you have to remember, because in those patients infected by these 3 viruses, approximately 70% of them will display thrombocytopenia. And the third subcategory of other reasons is autoimmune disease. For example, SLE, rheumatoid arthritis, and some other autoimmune disease, especially the autoimmune disorder of the thyroid. So in those patients, over half of them will display thrombocytopenia. Sometimes it's very severe. And other disease, for example, the lymphoproliferative disease, CLL, and lymphoma also cause secondary immune thrombocytopenia. You have to also pay attention to them. And also other non-immune reasons, for example, the cirrhosis, splenomegaly cirrhosis, also cause the medium thrombocytopenia. You have to pay attention. Many other reasons like DIC, like von Willebrand factor 2B disease can also cause thrombocytopenia. So a diagnosis of ITP is based on exclusion of all these reasons. And finally, if you cannot decide in a very difficult cases, there are 2 tests may be useful. The first one is an MAPA assay to detect autoantibody against glycoprotein on platelet surface, mostly glycoprotein 2B3A and glycoprotein 1B9. And this test is very specific for immune thrombocytopenia, and the specific rate is over 95%. However, the sensitivity is relatively low. Routinely, MAPA assay sensitivity is close to 50%. In other words, you can only detect antibodies in half of ITP patient, which is depend on the technique limitation. And the second test might be useful is a TPO level. A TPO level in the serum of patient may also very useful when a patient you cannot diagnose. And the use of TPO level detection is very common nowadays, and which can differentiate deficiency of bone marrow function or a proliferative bone marrow function, especially the megakaryocyte series. So to diagnose an ITP, you have to exclude all the other reasons. And if you still cannot decide, you can use MAPA and TPO level detection. And the second point that I will tell you today is the phases of ITP. And some 10 years ago, ITP might divided by 12 months or 6 months into acute and chronic. And if the course of the patient exceeds 6 months, that we diagnose them as chronic, or less than 6 months, we diagnose them as acute. But from 2009, the International Working Group of ITP recommended we divide them into 3 phases. One is acute, which is patient from diagnosis to 3 months. That is, if your diagnosis made within 3 months, then the patient diagnosed as acute. And if a diagnosis made over 12 months, then the diagnosis is chronic. Between 3 months and 12 months, we call it persistent ITP. And also, there are 2 kinds of ITP, namely severe ITP and refractory ITP. And severe ITP may indicate severe thrombocytopenia with platelet count less than 10 times 10 to the 9th, and with bleeding or with very high risk of bleeding. And the refractory ITP, the definition is very strict, which include 2 points. One is no response to first-line or second-line treatment, and the second is no response to splenomegaly or subsequent relapse after splenectomy. As you know, splenectomy nowadays is very rare. Not many patients accept splenectomy. So this definition might be changed in the near future. Thank you very much.